Thank you very much, everyone. Lessons from a failed Plan B. So this is 2006, so it's 16 years ago. 61-year-old male, hypertensive, presents with a single right carotid territory TIA with transient right arm and leg weakness 3 days before he saw me, and his duplex shows bilateral 80% carotid stenosis. And he underwent an uneventful right carotid endarterectomy with dual antiplatelet therapy, intraoperative TCD. Now, we knew the TCD that when you clamped his carotid, the flows were very low, about 5 to 7 centimeters per second. He had a normal angioscopy, and he went home on day 2. Very happy man. He came back 4 weeks later with absolutely no complications, and he goes, okay, what are you going to do about the 80% left carotid stenosis? Now, I went through all the controversies at the time, but my feeling was he was a young man, he was male, and he had a history of contralateral TIA, which we know increases the risk of stroke in medically treated patients. And his attitude was, my father-in-law suffered a major stroke and spent the rest of his life in a wheelchair, incontinent, unable to speak, and paralyzed. I will do anything to avoid that. So we scheduled him for a left carotid endarterectomy on the 30th of January 2006. At surgery, absolutely uneventful case. Dual antiplatelet therapy, intraoperative TCD, completion angioscopy. During carotid clamping, he had absolutely no detectable flow in his middle cerebral artery. But when you put in a 𝗏𝑇𝗏 shunt, the flows were restored to pre-clamp levels. There were no other intraoperative TCD abnormalities. As soon as his drapes were removed, i.e. before we'd started to wake the patient up, the TCD technician took the machine round to theatre recovery, because in those days we used to do 3 hours of post-op monitoring. But Mr. PG took just a bit longer than usual to wake up, and as I said to you earlier on, if people take a while to wake up, you begin to wonder what has happened. And that was unusual, because we'd had normal intraoperative TCD other than the low flow during the clamping before we put the shunt in, and he had an absolutely normal angioscopy. After 15 minutes, he was slightly moving his right leg, but not his right arm. He was obtunded, which meant he really wasn't conscious, and he had no speech at all. And we brought the TCD back to theatre, and we couldn't find the left middle cerebral artery waveform, whereas it was very easily detected preoperatively. Now, the clinical features that he has are absolutely classical of a total anterior circulation syndrome, and that is invariably, and I stress the word invariably, due to either a middle cerebral artery main stem occlusion or an internal carotid artery occlusion because of the severity of the symptoms. But we'd had no intraoperative emboli on TCD, especially during neck closure, which you normally see with an on-table thrombosis. And I'll show you an example here of an on-table carotid thrombosis in a different patient. Here's the cardiac cycle before we put the clamp on, and the velocities fall to 24. Here we've restored flow, and there's luxurious flow. And then you'll have to take my word for this, embolus, 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 embolus. And he's increasing embolization. And then down after about 20 minutes, his flows have fallen to what they were during carotid clamping. So this patient, this is not him, I'm just stressing, normally if you thrombose your carotid artery, you would get increasing rates of embolization, which we didn't see. So he's got a severe intraoperative stroke with evidence of either a middle cerebral artery, main stem, or internal carotid artery occlusion in the absence of preceding embolization. And I think I had a suspicion as to what had happened, and the clue was in my earlier talk, so I won't stress that now. I reckoned he'd probably had an acute internal carotid artery dissection, because that would account for the occlusion without preceding embolization. So my plan, we re-anesthetized him, I re-exposed the endarterectomy zone, and there was a normal pulse in the proximal carotid artery. I put inverted commas around that because feeling a pulse is meaningless. You get transmitted pulses. You can't tell if an artery is occluded or not just by feeling a pulse. So I did an on-table angiogram, and this is what it showed. And here you can see the upper reaches of the internal carotid. There's a dissection flap, and there's a spiraling dissection going right the way up to the skull base. And I think the reason for this is probably caused by even slight overinflation of the distal Pruitt shunt balloon that has caused a transverse tear in the distal internal carotid artery. So, remember, this is 2006, none of your clever stuff in the modern era. I had three options. I could do an on-table open repair of the dissection, and that would need exposure up to the skull base, and I showed you earlier how we do the mobilization. I could do an on-table stent insertion into the true lumen, but in 2006, there were no hybrid theatres. We had a C-arm, but there was no experience in the hospital of performing carotid stenting with a C-arm. And the third option was to transfer to the angio suite for stent insertion. But what you got to remember, that takes quite a while. I have a patient with no flow in his middle cerebral artery, so time is very, very tight here. Unless I get the flow back quickly, his left hemisphere is increasingly ischemic. So can I do a very quick poll? Who would do option one? Re-explore. Who would do option one? Okay, you can put your hands up clearly, you know. Who would attempt to put a stent into the true lumen with a C-arm? Okay. Who would transfer to the angio suite for a more formal? And the other 95% of you don't want to answer. That's absolutely fine. I elected to do an on-table open repair because I had a patient anesthetized in front of me with no flow in his middle cerebral artery. I've got experience of knowing how to open up the carotid up to the skull base, and I'm aware that my radiology colleagues said it's really difficult to find a true lumen with a C-arm in theatre of the standard that C-arms were in 2006. So I used the high approach, which I showed you earlier. The distal internal carotid artery was about 1.5 centimeters wide. It was tense and navy dark blue. I clamped the internal carotid at the skull base, and I made an incision in a fragmented carotid artery, and I put the Pruitt shunt into the true lumen, and instantly there's flow back in the middle cerebral artery. So I've now got a shunt in the true lumen, and I've restored flow. I'm feeling quite relieved. And my plan was, this is not his operative picture because medical illustration lost my photos from this unique case. I was going to do an interposition bypass graft in the manner I showed you earlier this afternoon. What was my first mistake? Now, what you got to remember, I was very experienced in carotid surgery, but even experienced people can make mistakes. I did not have any reversed vein over the distal limb of the Pruitt-Inahara shunt. I just had a Pruitt shunt in a true lumen. And without thinking it through, I decided to remove the shunt and place vein over the distal Pruitt limb and then put it back in to do the reconstruction. I removed the shunt, clamped, reverse vein on, and the flows are now back to 0. And when I tried to reinsert the shunt, I couldn't get it into the true lumen. Very fragile vessel edges, they were falling apart, very limited space below the skull base, and despite trying for a long time, I had to ligate the distal internal at the skull base with the flows still at 0. The patient was hemiplegic and aphasic. I saw him on the stroke unit on various occasions, and each time I visited him, he looked at me, and a gentle trickle of tears ran down his face, and mercifully, he died 3 weeks later. And I have to say, this case has haunted me ever since. Every time anybody tells me that there are no problems in operating on asymptomatic patients, this guy was... But what should I have done? In the modern era, with a hybrid theatre, I would have arranged for a stent to be inserted in the true lumen. But I can tell you, having seen how friable and fragile that artery was, when you put a stent in, I think, as we know with some of the acute type B dissections, you can get retrograde, and the artery may have split again with that. But on this particular occasion, the main lesson from this was, I should never have taken the shunt out. So if you ever get stuck in a situation like this, never take the shunt out of the true lumen. And what I should have done was I should have opened up the vein on the table, so harvest the vein, opened it up, and open it out, and I should have wrapped it around the shunt, and then reconstructed the vein as a kind of a conduit again. I may not have been able to complete a reconstruction because of the intense friability of the distal internal carotid artery, but I'm afraid this man's prognosis was cast by me, without really thinking about it, removing the shunt in order to do what was a perfect operation. There are times when you need to do an imperfect operation in order to get the best result. So if you ever have the experience of operating an acute dissection, never take the shunt out. This was certainly my mea culpa situation. Thank you very much.